I'm Bruce Cunningham, Dean of the Sanford School of Public Policy, and I'm pleased to welcome you here for this special event, one of a series during this inaugural weekend and throughout the academic year. We're celebrating the establishment of the School of Public Policy at Duke University's 10th school, and I'd like to thank all of you for joining us to mark this milestone. I'd also like to thank our public policy student ambassadors who are on hand this weekend to provide directions, sustenance, and answer any questions you have about life or Duke. And if you need anything, please look for them. They have blue shirts, and they're all very receptive to any needs you may have. As part of our growth, we're expanding our faculty and adding to the depth of the educational experience of our students. Among the experiences that help shape student career paths are opportunities to hear directly from policymakers and leading thinkers on major issues that affect their daily lives, which brings us to this program. Today's Terry Sanford Distinguished Lecture is made possible by a gift from the William R. Keenan Jr. Charitable Trust. Its purpose is to invite a distinguished person in public policy to deliver a formal lecture to the Duke community. For those of you who weren't at yesterday's lecture, which was terrific with Richard Fisher and Cokie Roberts, I should note that the endowment says of the Sanford lectures that they should be men and women of the highest personal and professional stature, such as presidents, prime ministers, and cabinet members, chief executive officers of corporations, visionary artists, and esteemed scholars. We view this lecture as our most prestigious because it honors both the founder of the Sanford School and his extraordinary public service, first as a member of the 82nd Airborne during World War II. I should remind you to turn off your cell phones. In fact, I got to do that too. Then as the greatest governor of North Carolina, as president of Duke for 15 years, and as U.S. Senator from North Carolina, and finally professor of the practice of public policy here at the school that bears his name. Past Sanford lectures have included Nobel laureates and heads of state. This morning we're honored to hear from Gale Rosseau, one of only a handful of women doctors in the demanding field of neurosurgery. Gail received her MD from George Washington University, where she also did her residency. She's the recipient of many honors and awards, including Chicago Woman Mentor of the Year and the American Association of Neurological Surgeons, American College of Surgeons Health Policy Fellowship. She's been listed in Best Doctors in America, Who's Who in America, and the Consumer Research Council's Guide to Top Surgeons. She also served on Barack Obama's committees, two of his committees, in his senatorial and presidential campaigns, acted as a surrogate speaker on health care issues during the primary and general presidential campaigns, and was until recently on President Obama's shortlist for U.S. Surgeon General. She is currently the chief of surgery at the Neurological and Orthopedic Institute of Chicago and director of skull-based surgery services at the Chicago Institute of Neurosurgery and Neuroresearch. You can see why I had to write this down, because it's pretty stuff. Dr. Rosseau will present remarks followed by a talk show-style discussion with John Harwood. They've been talking, I think, for the last 24 hours. I don't know if there's much left to say, but there's still a lot. John Harwood is a chief Washington correspondent of CNBC and a political writer for the New York Times. He studied history and economics at Duke and graduated magna cum laude in 1978. He began his career as a reporter at the St. Petersburg Times and advanced to state capitol correspondent in Tallahassee, Washington correspondent, and political editor. In 1991, he joined the Wall Street Journal as White House correspondent and later became the journal's political editor and chief political correspondent. In addition to his work as chief Washington correspondent for CNBC, Harwood offers political analysis on NBC's Meet the Press and PBS's Washington Week in Review, among other television and radio programs. He has covered each of the last 5 presidential campaigns, and finally, he's a good friend of Marty Morris on our Board of Visitors and a graduate of the Duke and Napa Valley Seminar, which is a very special honor. Following the discussion, John will open the floor for your questions, so please step up to the microphones on the Commons on the first floor, and upstairs there's one, so that everyone can hear your questions. As yesterday, we ask only that you keep your questions short and focused, in other words, that they be questions, not long statements. We're also grateful to Bruce Metke, a graduate of our program in 1978, for making the connection with Dr. Rosseau. They're long-standing friends, and Bruce will now provide a brief, more personal introduction.
It's a little like Monday Night Football. I'm doing the color commentary, I think, Gail. Thank you very much, Dr. Conaholm, and I can't resist saying happy birthday. I'm sure I'm going to pay for that dearly later. We could go into the first quarter on a gorgeous day doing justice to Gail's credentials, but luckily we have Dr. Conaholm and also Google, which does a great job and has changed the way we do these things now. So I recommend it to you, but you're going to have to do a lot of scrolling. I'll only mention two additional things in addition to what Bruce said, which are that you should look at Gail's YouTube presence, which includes counseling on matters from pituitary tumors to bicycle safety. You should watch them. They're really good. Well, at least the ones on bicycle safety. And the second, from a pure policy perspective, she's been a strong, active public voice for several causes, including research funding for the study of Alzheimer's disease, the advancement of women in professional life, and head and spine injury prevention. But really, I'd like to change the focus for a very brief moment, really just to make one point. I think we're all students of leadership here, some older than others, but sadly, it's not a universal principle that admirable leaders always lead admirable private lives. Yet, throughout her career, Dr. Rosseau has been an integrated and ethical leader, a mentor and energetic contributor in all aspects of her public and private life. She's been married to her husband, Rick, for over 25 years. She has two very accomplished and eloquent children who are making significant contributions in their own rights. They, at least, are not intimidated by their mother's academic credentials. Dr. Rosseau, in addition, has become bilingual as an adult and uses her language skills to build friendships among neurosurgeons and people literally around the globe. And with a little luck, she will complete her 12th marathon next week in Chicago. So while I have no doubt that she'll provide us with some very interesting things to think about, as helpfully elicited by John today, I think we should keep in mind that this is someone who puts as much time and effort, astoundingly, into her children, her mentees, and her friendships as she does into her profession and her politics. Gail, I'm delighted to invite you to Duke and to have you be welcome here, and to the Sanford School. Please join us. Thank you.
Thank you, Bruce. And all of us who are parents in the room, and I trust there are many, know that the hardest job to do well is to be a good parent, and I really appreciate those very personal remarks. So do 15-year-old Natalie and 13-year-old Brendan. Well, Dr. Cunningham, Mr. Harwood, members of the Duke Board of Trustees, Sanford School Board of Visitors, and members of the Duke family, it is both a pleasure and a distinct privilege to share this podium with individuals I so admire, while honoring the legacy of one of the most respected scholar, statesman, and gentleman of our time, Terry Sanford. One of the themes of the day appears to be the integration of ethics and insights gained from non-policy experiences into the crafting of good public policy. And Terry Sanford is perhaps the best example of such a composite formulation. Lawyer and professor, FBI agent and university president, governor and senator. His life was devoted to fighting the good fight, whether the battle was against Nazis during the Second World War or against racial segregation during the troubled civil rights era. Time has shown Terry Sanford to have been on the right side of many issues. It is this sense of purpose and commitment to social justice, gained from seemingly unrelated life experiences and woven into a career of public service, that makes the model provided by the life of Terry Sanford so compelling for us today. It is also perhaps why we have the unlikely prospect you see here before you of a practicing neurosurgeon addressing your Sanford School of Public Policy. There is something intensely American about our desire to see worker bees, like me, affecting the broad sweeps of public policy. And maybe this is why, in America last year, a community organizer was elected President of the United States. Terry Sanford and those he inspired would surely want us to discuss health policy today. In 1963, speaking of ending job discrimination for African Americans in North Carolina, he said, "We will do it because it is honest and fair to give all men and all women their best chance in life." And I believe that Terry Sanford, were he with us today, would be a leader in the fight for health care reform. It is good for us to remember the long view of history when we approach this subject. What we are trying to do in public policy is both very hard and of critical importance. It is the life in the Jeffersonian formulation of life, liberty, and the pursuit of happiness. The personal, private, efficient, affordable, and innovative healthcare system we seek will be extraordinarily difficult to design, pay for, legislate, provide, and monitor. So difficult, in fact, that we as a nation have tried several times in the last century, failing or only achieving partial results each time. But the mood of the nation and the impetus of the financial crisis have led us to put our system of healthcare delivery on the table once again. It won't be easy, and it won't occur quickly, but we must begin. In the emotion of the town hall meetings last summer, and with the soporific effect of 1,000-page healthcare reform bills, it is easy to lose sight of what we want to accomplish. Consider the truth and near universal acceptance of this simple statement. American medicine is among the best in the world, while the American system of healthcare delivery is one of the worst. Our task, then, is fairly straightforward. We need to preserve what is good about the American medicine while improving the system of its delivery. I need hardly tell an audience from Duke University about good medicine. We have an example of excellence in Duke medicine here today in Professor Friedman. One of the best academic medical centers in the world is right here. Dignitaries from Boston to Beijing have sought cures and compassionate care at your fine facility. And American medicine outside of Duke is good as well, and getting better. Here are some examples from my own field of neurosurgery. A craniotomy to remove a brain tumor, one of the most common operations I perform, has changed dramatically in the 20 years since I learned how to do it. That procedure 20 years ago took most or all of a day. It involved a week's hospitalization, a dramatic and traumatic shaving of the head, and 3 months off of work. It is now routinely performed in 2 to 3 hours with intraoperative image guidance that allows small or even no incisions in some cases, no shaving, 2 to 3 days of hospital stay, and a return to work in 4 to 6 weeks. Dangerous tumors that are invisible on MRI can be detected and removed endoscopically by the use of surgical telescopes inserted through the nose. Potentially lethal aneurysms are managed successfully by coiling, which is the insertion of tiny metallic coils through the top of the leg that travel all the way to the brain and prevent dangerous bleeding. Worn-out spinal discs and seniors with memory problems that improve with spinal fluid shunting are treated in operations that routinely take just under an hour. And every field of medicine can cite similar examples. Every institution can cite patients who travel great lengths to take advantage of the benefits of American medicine. Our doctors, researchers, and medical entrepreneurs have mined the ideas from an increasingly flat world, and our free enterprise system has allowed progress to be made at an astonishing rate. Nanotechnology is promising to allow biomedical engineering at the atomic level, bringing us to the threshold of unlocking the secrets of illness and aging itself. Yet our system is cumbersome at best and wildly unfair at worst, and its cost is unsustainable. For physicians, our patients provide us a window through which we can clearly see what works and what doesn't work in our healthcare system. Again, some recent examples from my own practice. A 34-year-old mother of 2 who wants unnecessary brain surgery. We've been following her benign tumor with periodic surveillance exams and imaging studies for 4 years. Her neurological situation is stable, and unchanged, but her employer is changing health insurance plans, and she needs and wants to have surgery now, both for coverage of the procedure as well as to be insurable in the future due to her pre-existing condition. Or consider this, a woman who is scheduled for surgery on her neck by a local neurosurgeon. The high reimbursement for the procedure is unavailable when workman's compensation rules that it is not a work-related injury. She has no other insurance, and her surgeon cancels her surgery and recommends further physical therapy and aspirin. Or a couple I have cared for many years inform me that they are retiring at age 60, but are planning a move to Mexico so they can access health care from the Mexican government until they reach the age of 65. Or a 25-year-old man who sees me for persistent low back pain after a minor motor vehicle accident, a fender bender. My suspicions are confirmed when his MRI shows a spinal cord tumor. I recommend the only appropriate treatment, which is surgery. He, his fiancée, and his parents are upset. $15,000 has been set aside for a Hawaiian honeymoon, and they do not want to pay for surgery or hospitalization or insurance. And this story, my personal favorite. A young couple, a Montessori teacher and a taxi driver, look up doctors on the internet and come to me for the brain surgery she needs. When asked how they chose me, they tell my nurse, well, she looks nice in her photo, and besides, as a woman, she's probably not the only breadwinner in her family, and she can better afford to do the surgery for free than a male surgeon. So we're not talking about labor policy or gender differences today, but these real-life examples point out the absurdities in our current system. They represent just some of the widespread systemic problems that must be changed. Lack of portability, inavailability of best practice standards, inequalities in coverage and in compensation for treatment, lack of shared risk, lack of personal responsibility, and finally, an unsustainable model that in too many cases relies on the personal benevolence of doctors and other providers of health care. A new national order must be created for reducing error and paperwork, opening access and portability, and controlling cost. Once again, the medicine is good, but the system of delivery is bad. Now, thought leaders from many segments of the population have stepped forward with valuable insights. As an academic institution, the faculty and students at the Sanford School are accustomed to reading lists, and I would suggest just a few in addition to your own excellent publications on the subject. There are a few clear voices that I think are particularly valuable in this debate. From surgeon Atul Gawande and internist Jerome Groupman, to Oregon's Ron Wyden from the Senate Finance Committee, and former Speaker of the House Newt Gingrich. Some of the brightest minds in America have weighed in on these issues. But the debate continues, and further delays occur. Our democratic and representative form of government is messy. It calls for rational analysis to take the long view of policy, formulating programs by collection of empiric and objective data. And this always sounds good, but it's always frustrating, and it often fails. The Constitution divides power among many, and our enlightened self-interest further drives us away from coherent and deliberate policy choices. Thus, the health care reform bill that eventually emerges will be the result of votes informed by those who most care about how the bill will affect their particular part of it, from jobs in one's district, to cures for one's own disease, to compensation for one's work, to shareholder profits. And healthcare policy is probably not best done by those who must regularly appeal to special interest groups for campaign contributions. No wonder Abraham Lincoln once declared that he would rather swallow a chair than make a short-term decision that he knew he had to make. But what made his place in history was his ability to see the opportunity for what it was and to do the right thing, no matter how much it caught in his throat. So please permit me to make some observations, to outline some questions and decisions that strike me as important to a discussion of healthcare policy, and then we'll actually discuss it. First, some observations pertinent to the debate. Number one, Healthcare is a shared resource. Its cost is too high for most individuals, and tax money for equipment and personnel is not available in unlimited supply. Number 2, inequality, lack of equality in economic resources is a natural feature of a free society, no matter how uncomfortable this fact makes us. And number 3, capitalism and ethics must coexist in a functional system. Personal benefit must be part of incentives, but must be at arm's length from most treatment decisions. Next, some questions to consider when framing our discussions. Should we approach healthcare as we do education, creating a multi-tiered system? After all, not everyone can afford to attend Duke University, nor even has the wherewithal to know that they should want to go here. What is the extent of permissible inequality? We are all familiar with the decisions involved in flying coach versus first class, or even in having our hair cut by a student stylist versus an experienced barber. What about surgery done by an intern versus an experienced surgeon? What restrictions on personal liberty in the name of fairness are we willing to allow? Already, we have required reporting of communicable diseases, necessary immunizations, mandates for emergency care, mass casualty scenarios, and the like. And speaking in purely practical terms, who pays? And do we pay fee for service or fee for no service? And finally, some fundamental decisions must be made if we are to move forward on healthcare reform. We must decide how much of our gross domestic product we wish to spend on healthcare. We must decide to what extent we wish to incentivize those who actively pursue healthy lifestyles as a matter of personal choice and cost reductions as a matter of personal practice. Now, while I do not have all or even some of the answers, I do have some suggestions from a provider's perspective, some modest proposals, if you will, for beginning policy work toward a better system of delivering health care in this country. As the very timing of the effort has been a big part of the controversy, I have labeled them short, middle, and long-term suggestions without defining those time periods. So, some short-term suggestions, perhaps for discussion later, may include the following. Number 1, make all costs transparent and discussed by doctor and patient. Both parties need to know what pills, tests, and procedures cost. This is called health economics literacy, and we can simply no longer afford to be illiterate. 2, nothing should be free for able-bodied adults. Unless you are a child, a senior, or have a mental illness, you should participate in some way in your own health care so that you will value it. Number 3, reach early for low-hanging fruit. Use the health information technology to decrease fraud, abuse, error, and duplication. This may also be an efficient way for clinicians and policymakers to interact with key drop-down menus at critical steps in the healthcare record of patients that can be mined for analysis, reflection, and course changes when appropriate. 4, consider allowing providers a tax benefit for providing free care, at least as a bridge during a transition to a fully insured populace. 5, allow interstate competition into the health insurance industry. And number 6, while speaking about that industry, keep costs and co-pays low. Health insurance may not need to be a profitable industry. 7, mandate the purchase of health insurance, sharing risk between the healthy and the less healthy groups. This will allow carriers to provide immediate portability among employers and stop eliminating patients who have pre-existing conditions. And 8, create a Federal Reserve Board for healthcare costs. We all know that the only real way to stick to a budget is to decide in advance how much you want to spend and then stick to it. Until now, the pressure of special interest groups has been too strong for Congress to resist. It may be time to consider an autonomous agency, like the Federal Reserve, to oversee and determine how Medicare dollars are spent. And this may be an appropriate first step before creating another government program in order to assure the overall success of the healthcare reform effort. The rapid and effective response of the Federal Reserve during the recent financial crisis worked pretty well at allowing Americans and the rest of the world to remain confident in the U.S. banking system. Some midterm proposals to consider might include further responsibility on professional medical societies, which must establish recommendations for best practices. This may sound easy, but it is not. The politics of professional medicine are as real as the politics in Washington. There is seldom, if ever, a single right answer. There may be several good treatment choices, and they may vary widely in cost. Surgery and surveillance are the outliers in this example. Prevention is always worth a pound of cure, but is not always a good way to save money. For example, the use of statin drugs, a mainstay in the treatment of high cholesterol and the prevention of heart disease, are estimated to cost $150,000 per year of life saved. We must find creative solutions to improve the medical liability climate. As federal tort reform has not gained traction, other alternatives, such as safe harbors, health courts, or some other formulation of disclose, apologize, and compensate, must be developed to preserve the doctor-patient family communication when poor results occur and to minimize the deterrent effect of the current climate. Finally, long-term proposals will guide the nation to think about our health and our health care going forward in fundamentally different ways. Over time, the health of the nation must be shaped by a new generation who have been educated as a student health force, whose curriculum has provided them with health literacy, who know their own ideal numbers, as well as their parents' and their grandparents' ideal numbers, on a wide range of important metrics, including blood pressure, blood sugar, and cholesterol, just to name a few. The student health force must be certified in CPR and trained in violence and injury prevention. They must pass age-appropriate physical fitness tests, just as they now pass tests in reading and mathematics. And if they choose a medical career, there must be tuition support, so they will not emerge as doctors holding six-figure debts for their medical training. So let's summarize some key concepts regarding the formulation of a good, durable health insurance, health care policy for this country. Policymakers should know that physicians want to have input. The criticisms of doctors and other centrally managed systems is that they don't have input and can become victims of federal policymakers. Physician input is valuable, and in the computer age, we must formalize this input. The business of healthcare must be regulated by both ethics and common sense. Patients do want their surgeons to have input into the formulation of implantable devices. They do not want their surgeons to make millions doing so, nor do they want this involvement kept a secret. Physicians need to know that we can be helped by policy. Examples include the 80-hour work week restrictions for residents in training, community efforts for large-scale threats to the public health, and safe harbors for those who follow consensus guidelines for best practice. As I close, I would argue that we are embarking on a fundamental shift in the way Americans relate to government and to one another. As President Obama has so eloquently stated, our destiny is not written for us, it is written by us. But democracy and representative government, as we said before, are messy. Students of history in the audience may know of Gordon Wood's 1993 Pulitzer Prize-winning book, The Radicalism of the American Revolution, in which he argued that the American Revolution was, most fundamentally, a revolution in human relations, from order to anarchy, and from hierarchy to equality. We saw some anarchy this summer at town hall meetings. Some have argued that this was created for the benefit of the media, just as they did in Samuel Adams' time. Moving from hierarchy to equality is hard for the hundreds of millions of Americans who do have health insurance, many of whom are content with the status quo. But 200 years ago, America and Americans changed from a people who knew their place to a people who made their place. To providers, and especially to doctors, I would recall the rich legacy of important policy work left to us by the 4 physician signers of the Declaration of Independence: Benjamin Rush, Josiah Bartlett, Lyman Hall, and Matthew Thornton. The demands on their time during the 18th century, during which they practiced medicine, were surely no less than the demands on our own time, yet they provided needed leadership and expertise in the public policy arena. We physicians must view ourselves, as they did, as having 2 specialties. One is the specific area of medical care which we have each been trained to provide, and the other is the public health. To the policy experts in this room, I would remind you how very healthy it is to take a dose of the practical along with the theoretical when crafting public policy. I would encourage regular, routine examination of a policy idea with a practicing provider and finding ways to formalize and even incentivize such best practice habits in the formulation of health policy. We must be both careful and collaborative. And finally, for those who would endlessly delay or derail the healthcare reform effort because it is too complex or too difficult or too political, I would remind them of the call to action by one of our most activist presidents, Theodore Roosevelt, who said, "Far away the best prize in life is to work hard at work worth doing, and healthcare reform for America is work worth doing." Thank you very much.
Okay, a couple things before we get to the meat of the discussion. First of all, were you suggesting that those of us in the media might be taken in by this images of a few crazy people screaming in the face of a U.S. senator?
Like they were by the Boston Tea Party.
I'm shocked that you think that. And second of all, that woman who liked your cute picture on the internet and realized that you weren't the primary breadwinner, did you give her a good deal on the surgery?
Well, that was 6 weeks ago. We're still working it out.
Nice, nice. The one thing that you didn't hear in the introduction about Gail was that she was also a really good high school cheerleader. Okay, true.
Not that good.
Yeah. First of all, let me just say I'm really happy to be here at the opening of this school. Terry Sanford was not just my university president when I was here in the mid-1970s. He's somebody that I had heard about before I got to school because my dad was a journalist who he worked at Southern newspapers in the early part of his career, the Washington Post later, and he covered Sanford when he was governor. And I remember him telling me when I went there, my dad was a pretty tough critic of politicians, but he told me that Sanford was one of the good guys. And I always sort of carried that idea around with me, even as he twice unsuccessfully ran for president while I was here at Duke. It didn't work out for him. It worked out for Carter better than it worked out for Terry Sanford, but he was a good guy. I'm also happy to be having this real substantive discussion with Gail and you guys on healthcare reform, because this has been like a year, a sort of good news, bad news year for me. The good news is that it's been really exciting to cover Barack Obama and his new administration, and I've interviewed him 3 times this year. He's a terrific interview. I was really proud of those conversations, but it wasn't exactly the Sanford School stuff that got the attention when I did those interviews. In January, what everybody cared about was him talking about getting photographed without his shirt on the beach in Hawaii. In June, it was that he killed a fly while I was sitting there talking to him. And 2 weeks ago, it was because he called Kanye West a jackass. And which is something he actually said to my daughter, who came to the interview with me, and we had been talking about Kanye West interrupting Taylor Swift. I know some of you don't even know what I'm talking about, but some do. But we're drilling down here, the real stuff. So let me first ask you about one of the issues that came up at the town hall, which was incendiary, and it sounded ridiculous at the time. I'm talking about the death panel issue. But there's a core of reality behind the idea, which is that we spend so much money on end-of-life care that makes marginal or no real improvement in the quality of life or longevity of people. What do we do about that?
That is a really good question, John, and it's something that we just need to talk about because there is so much commonality in the way patients and families feel about this. There are in 25 years in medicine, I can count on less than one hand the number of individuals or families who wanted to be kept alive on machines, unconscious, no matter what. I mean, it's nearly universal that most of us want to work hard, do everything possible to hang on to a life that has consciousness and meaning, and we have variations in how we define meaning, but the simple in and out of a ventilator does not provide meaning for the vast majority of people, but yet there's a lot of healthcare expense that goes to that. Just because our hands are tied, we don't know what the advanced directives are of individuals, or their families don't know. And so because it is literally a life and death issue, we have to and always do err on the side, the expensive side of preserving life. But there are many
So who says no? The Federal Reserve Board that you're talking about?
Absolutely not. There's something called advanced directives that we should all have. It should be in our wallets. It should be in our safety deposit boxes. And when we are well, we should have these conversations with our loved ones about, in the event of a change in our health status where, you, my spouse, my mother, my son are making decisions for me, here's what I want, and please carry out those wishes for me. If we did just that, we would save a lot of money.
Right, but we can do that now, and we're still spending all this money. Are you saying that the answer then is nothing that government would do, but in terms of making decisions one way or the other, but simply exhortation to people to have advanced directives? And can that really get to the problem anytime soon?
Yes, it can. And that's where there's been some political spin put on the most recent health bill. There's nothing that says we're going to establish death panels that decide when to pull the plug on grandma.
Right, but I'm wondering whether we need something, not death panels, but whether there is a real argument for rationing, and how do you affect it? I was talking, I did a panel at the University of Wisconsin earlier this summer with Dick Gephardt, who used to be the majority leader of the House, Tommy Thompson, who was the HHS secretary under Bush, and a bunch of providers. And they all said, yes, we need to have much less end-of-life care than we do now, but it is too volatile. Politicians can't touch it. And then the question was, well, how do you do it? And they were talking about, well, providers have to have a more coordinated effort on describing what best practices are and educating people, and there's advanced directives and all that. I just wonder whether any of that is a near-term solution to our cost problem.
Well, this is part of this effort I've described as a student health force, but at some point we can all be students. There are things that we could be doing right now that would avoid a lot of unnecessary expense without any rationing at all, just by knowing up front what the wishes are of people when they're healthy and conscious, so that we can carry out those wishes, which generally are not, please put me in a nursing home on a ventilator until I am overcome by pneumonia. That's not the wish of most people, and yet the default position is the more expensive one, and that kind of cost saving would involve no rationing of any kind. It would just involve a conscious effort for us all to do what we should do, which is make decisions ahead of time that are personally, morally, ethically appropriate for ourselves and our loved ones, and then document that so that doctors and other providers can act upon them.
Let me just refine the discussion a little bit by exploring what you think would be right in the ideal, and then get to practically where we are in the Congress. Single payer. merit to that? And how would that be a good idea for on equity grounds? But secondly, how would you perceive what it would do to quality and the, as what you mentioned, what's best about our system now?
Well, that is the million-dollar question.
Yeah.
I mean, that's the whole question, is
Right.
single payer or not. I think that we as a nation have done very well by the capitalist system, which incentivizes competition, and that you and I, all of us know, just sort of in our very core, that if there's competition, we do better. The individuals fight it out to do better. Having said that, if there's a way that we can create a formulation, and it may or may not be these health exchanges, where there is both competition but also a streamlining of the inefficient and expensive paperwork that that's the advantage and the attractiveness of a single payer system. That, you know, in our situation, we've got 20 doctors and nearly 300 employees who are churning the paperwork that our medical activity generates, and that's really ludicrous. A single payer system would help with economies of scale, but it would not help with incentivizing best practices. So some kind of formulation of the two, taking the best of both of those conceptual frameworks, I think.
So you're
will serve us
against
better.
single payer in itself?
I didn't say that.
Sounded like it.
I am in favor of those elements of single payer that would allow us to streamline the process. But I'm against a non-competitive system, and that's why I offered perhaps the exchange system where there would be multiple exchanges, but where, in fact, I'm not convinced that the healthcare industry needs to be a profitable industry and give a return to its investors. But there does need to be competition, I think, so that patients can have options, so they can pick up and move if they're not getting good service from their employer, from their insurers, just like they can if they're not getting good results from their doctors.
Let me go to another end of the spectrum, not the other end, but another end, and then I'm going to come back to health insurance industry and the profitability that you mentioned. You talked about Ron Wyden before. Ron Wyden, as you know, has a bill.
Healthy Americans Act.
Which has bipartisan support that would eliminate the tax exclusion for employer-provided benefits, shift it into an individual credit, and really turn the table over of the healthcare system that we have now. A lot of health policy people that I've talked to think that would actually be the ideal way to go, and the question is, can you get there from here politically, which the Obama administration has decided you can't. Do you agree that what Wyden is talking about would be the ideal way to go?
Yeah, I don't know if it's the ideal, but it is definitely a step in the right direction. I'm familiar with him, and I know him well, actually, and his bill, and I think it's a very logical first step. It makes good sense, and I think it's a move in the right direction. Now, what's sad about Washington these days is that a centrist Democrat like Ron Wyden gets it from both sides with that particular proposal that he has in the Healthy Americans Act, where he is both vilified by Republicans for even suggesting this, but he's also vilified by the extreme left of his own party, to the point where he's facing...
And the White House just wants him to shut up because they think he's impeding their problem right now.
And yet, to me, his formulation is a very Sanford school kind of formulation. It is an informed, thoughtful, collaborative step in the right direction.
The health insurance business. Your buddy, Barack Obama, is going around making speeches.
Even though we didn't get the Olympics for Chicago, he's still my buddy.
Yeah. Is going around making speeches talking about the obscene profits of health insurance companies, suggesting, sort of demonizing them a little bit, suggesting that they care about themselves rather than their customers. To some degree, that's being done about pharmaceutical companies as well. As somebody immersed in the system, when you think about insurance companies or drug companies, do you think bad, evil, money-hungry, or do you look at the incentives of the system and say, it's a system problem, it's not the behavior of the people in those institutions?
Well, I think it's both. I mean, there's greed in most human activity, and doctors aren't excluded from that, patients aren't excluded, and nor are pharmaceutical or insurance companies. But I think one of the reasons why we've had such an impasse is because we're in this very curious kind of circular firing range where everyone's shooting at everyone else within it, and we're not really focusing on what we can all bring to the table. Everyone's going to have to give a little and get a little. That includes doctors, insurance companies, pharmaceuticals.
Do doctors need to make less money under a reformed health system?
They need to justify, we need to justify what works and what has value and what doesn't. Just doing another operation doesn't necessarily add value. We need to respond to the public and the government's very legitimate call for us to establish best practices. Where is it going to happen if it doesn't happen in professional medical societies? And this has to happen. You know, Alan, as well as I do, that it's very hard in neurosurgery circles for us to take a stand and say treatment A in the neurosurgical world is better than treatment B. We should be well compensated for the one that shows merit and value, whether that's surveillance or surgery or something in between, and to a lesser degree compensated for something that's just a pile-on because it's a fee-for-service.
Could we still have the best medical system in the world if our specialists, like the fancy pants neurosurgeons, made a little bit less money, and the general practitioners maybe made more? Or do you see play in that
First
system?
of all, Alan Friedman's my friend, and his pants, all fancy, are not too fancy. And certainly not fancier than yours. Would you like to just go on to your next question?
I'm not letting you off the hook on that one.
Look, doctors are well paid in this country, and I make no apologies for that. And in fact, patients like to know that what we do as doctors and as other healthcare providers is valued and is compensated for. So I make no apologies for that. I think that we need to do a better job of justifying of identifying what within our work product really has merit, the things that are really making a difference in the public health. Be well compensated for those, and then get rid of the things that are really just add-on, the repetitive tests, the duplication of effort, the doing yet another and another and another radiation treatment for someone in their last 6 months of life. Those are the kind of things where we're going to need to be able to start making, it's not even decisions, it's really demonstrating with good evidence-based studies or even current practice what seems to be making a difference and guide our reimbursement in that direction. Well,
you're just touching on some of the things that I think make it a real challenge of comprehension in the healthcare debate. Now, people are very confused about how you save money in healthcare, if you can save money in healthcare. President Obama talks about not adding one dime to the federal deficit while insuring another 30 million people, and a lot of people look at that and say, "Come on, you can't do that." On the other hand, in this legislation, they're talking about doing a bunch of things that health policy people think would have an impact or might have an impact on cost. You don't really know because a lot of them haven't been done. They can't be scored by the Congressional Budget Office, that sort of thing. But tell me what you think, honestly, in substance, it adds up to, whether you're talking about things of real promise when you talk about chronic disease management, reducing hospital readmissions, electronic medical record, best practices, all of those things. Are those little kind of drops in the ocean, or are those big things?
Well, let me tell you what I think the biggest thing is. We just had a debate about this at the Institute of Medicine in Chicago on Wednesday night. And the estimated costs, healthcare costs, of behaviorally mediated diseases are about 50% of our budget. And what do we mean by that? We mean the cost of all of those things that we as patients, as individuals, as citizens, as taxpayers do, is about half of our costs. So that includes smoking and obesity and diabetes and all the salt and sugar and whatnot that we eat. And so if we really want to save costs, if that's 50% of what we're spending, then it really does require a revolution in how we think about health and about many industries, not just medicine per se, because the fast food industry, the things that are on the shelves in our supermarkets and the cafeterias of our schools, they are all contributing to these costs that are not sustainable and are not helping us or our health.
So the people talk about taxing sweet drinks, getting Fritos out of the machines at the high schools and everything. How do you, as a parent, as a citizen, how do you think about the merit of those ideas versus the government intrusiveness, the heavy hand of government telling people what they can eat and what they can't?
Those are tough problems, but I think that erring on the side of health is a position I would be willing to take.
So you're kind of a radical then.
It's the radicalism of the American Revolution that we're talking about.
Nice, that was good. A couple more things before I go to questions from people here. Malpractice, defensive medicine. I've been covering that argument for 25 years. When I was covering the Florida legislature, huge fights every year, doctors and lawyers, insurance companies over malpractice. And honestly, it's never been clear to me whether it's a perennial political argument, but is defensive medicine and the malpractice cloud hanging over the physician community a huge problem, impediment, cost driver, or is it a small problem?
I think it's big. It's been estimated to be anywhere from 1 to 15% of our costs, so nobody really knows. There's the costs that are actually associated with litigation that are small. Probably that's where the 1% number comes from. The 15%, the outlier on the other side, is all of those tests that we order that are a CYA kind of test ordering. You do it even though one was done 3 months ago because you just want to be sure you can't afford to ever make mistakes.
Do you order a lot of those CYA tests?
I order some. Every doctor I know orders some. And, we also don't have crystal balls. And sometimes we do it thinking we're just doing it to be safe, and lo and behold, we're really glad that we did it. So we need metrics on when we should do it and when we shouldn't do it. But in terms of the whole liability climate, I think what we need to get to is a situation that's more akin to what's happening in the aviation industry, where, anytime you do things that are dangerous, whether you're flying a plane or taking out a brain tumor, there will be errors and there will be poor results that occur. And we need to have a non-punitive system in place that allows us to catch and treat not only those things where there's a poor outcome. The aviation FAA doesn't only look at crashes, they look at near misses. And we need to have a way to, every patient, every time, improve the system by, in a non-punitive way, looking at all these things so that we can always be moving toward our best practice, toward better practice.
Last question I'll ask you before we go to audience questions. A lot of discussion about the so-called public option in health reform. The Finance Committee is moving toward a bill, around $900 billion over 10 years, that would mandate that everybody get coverage, subsidies for people who can't afford it, penalties for people and employers who don't obtain or provide coverage, but not at this point a public option, which Obama has said he was for, but he was flexible about. Important or not important?
Well, this gets back to, the single payer and the public option I see is really the same formulation.
Because I personally don't see why it's that important, in the sense that, it's important if you believe in single payer and you want health reform to take you toward single payer eventually, then you must have a public option. But if the goal is to get everybody in the system, and you do that through the individual mandate, and you have subsidies to allow people to get coverage, if you do those things and you take steps to address cost, which is the other priority that Obama has talked about, I don't see why public option is vital unless it's critical as a cost control. But do you see it that way?
No, it's become a buzzword for whether you
Right.
care about the health of the nation or not. And I
Right.
think it's become a little bit too politically charged of a term. I mean, let's look at what do we really want to accomplish. We're the richest nation on earth, and it is absolutely uncivilized that we have so many Americans without health insurance. So we need to cover everyone, and that's a first step. And we probably don't need a public option to do that. And then we need to sequentially improve this very broken system that really isn't a system at all, but just a hodgepodge of the way we do it, and try to craft a system of that. And the issue has really become timing. And again, that's politically charged. If you want it now, then you really care about it. If you want to do it in stepwise fashion and be sure we get it right, then somehow it's un-American or it's a delay tactic. And I would say we have to work on it now, day in, day out. We don't have to pass it today, but we have to be hoping to pass it today or tomorrow, the next day. But we don't just want a bill. We want a good bill, and we want to get it right.
Quick show of hands before we go to questions. How many people in this room believe that Congress this year will pass a meaningful health care reform bill?
I think we will.
And how many people think that will not happen?
Oh, wow. It's about 50.
Okay, the people who said it will happen, you're right. Okay. That's just my prediction. Yeah.
Well, that's it.
Who's got a question? Oh, sorry.
Yeah, come to the mic. That's right. The White House is watching now and hearing what we're all saying.
All right, there
so
we
we want to
go.
be sure they
That's
hear
right.
what you have to say.
On the subject of cost reform and cost cutting, don't you think a public option is relatively necessary to provide that competition that you were speaking of before in terms of helping to negotiate lower costs? I mean, the insurance companies themselves don't seem like they're going to go that way by themselves. And I'm wondering if the public option or some sort of public option is actually necessary, especially in terms of negotiating volume discounts. I mean, this seems to me to be one of the best ways to leverage part of the cost problem we have in terms of just negotiating, be able to say, well, we are covering these many people. Everybody else gets a break when they buy in volume. Mm-hmm. Why shouldn't the pharmaceutical companies give the government or a quasi-government entity a chance to do that sort of negotiation? Don't you think that that's kind of an essential element in driving costs down?
Well, that's a very good question. In fact, that's the main reason why there are advocates for a public option, is to be able to have these economies of scale. And of course, the main argument against it is that there will be such a competitive advantage of a public option that all competition will cease to exist, because there will only be one gorilla in the room, and that will be the public system. So some kind of formulation that both allows economies of scale but also allows competition so that patients, which is all of us, have some choice, I think is the best formulation.
Mm-hmm. Some choice, and it doesn't necessarily need to be a gorilla. I mean, it could be, you could function it that way, but you can also design it in such a way that it doesn't have to be the overwhelming source.
Well, you're absolutely right. That's why we need the smart graduates of the Sanford School to help design that.
Yeah.
And I wish I'd gone into health policy rather than environmental
Yeah.
policy.
Charlie.
That's a wonderful talk you gave, Dr. Rosseau.
Thank you.
You posited at the very beginning that we had to make a decision about how much we're going to spend on health care. But I would also posit that the thing that makes American medicine the best in the world for the people that receive it is the fact that it's the most innovative. And part of the reason that we have driven costs up, in addition to all the others that you have cited, is that we are terribly creative in terms of producing new diagnostics and new therapeutics. How do we keep the innovative incentive maintained at the point that we're continuing to add on these cost-provoking technologies and have a ceiling? I don't know the answer, but I think it's a real dilemma for us.
That's a big question.
That's a great question, and I agree with you. I am of the opinion that American medicine is among the best in the world for just the reasons that you cited, and we don't want to lose that. That would be an absolute tragedy if we misconstrued our desire, our appropriate desire, to make this great system available to everyone. So our inclusivity became a drive to mediocrity. We can't let that happen. We need to tweak the system in such a way that we have both a capitalistic, we're all here, we live here because we believe in the capitalistic system. That means that if I work harder or have a better idea, I'll
Or
be
just because we were born here.
Yeah, but there's not a lot of people who leave here to move to North Korea. I'm not seeing that, John. I don't think you are either. In fact, it's the other way around. So we know that works. So, we have to find a way of crafting a policy that allows individual bright people, graduates of this school and others, to have some personal benefit, but not out of bounds personal benefit where greed takes over, so that their bright minds and innovation help them, but help the general populace. Thank you.
Two things. First of all, I was reading an article which said that we in the United States do something like twice as many MRIs than any other country in the world. And I maintain that the reason we do it is because it's available. Mm-hmm. If you had to go 100 miles to get an MRI, you probably wouldn't get it. But I don't know how many MRIs or machines are available in the city of Durham, but I suspect there are a fair number, some of which are freestanding. Mm-hmm. So I think that some of those costs can be cut back by the fact that we are, in fact, ordering these things when they don't really need to be done.
But how do you put that genie back in the bottle when you have available machines? And in fact, technology is making this stuff easier. I'm sure there are diagnostics you can do sitting in front of a camera on your iMac. The doctors can look at you and do stuff. How do you create limits again for something that's ubiquitous now?
Well, you don't pay for it. If all these MRI centers are there, but MRIs are not reimbursable, they will either find a more useful use of that machine, or they won't stay in business.
Let me ask you a question. I'm a gatekeeper. Mm-hmm. I'm a family practitioner. Mm-hmm. When you go and look at the medical schools, very few people are going into the primary care. Why? Because they don't make very much money and they work very hard. Do you see anything happening in the future which is going to try and direct medical school
Income
students?
Redistribution.
That's what Okay?
I have a better idea. I've only known John for 24 hours, but I almost always have a better idea on these things than he does. No, I mentioned in my talk, medical students who, maybe there's someone here from the Duke School who can tell me, the School of Medicine, what the tuition is here. But when you finish 4 years as a medical student, you typically have a 6-figure debt to pay back. And just do the simple math. You need to go into a more lucrative specialty if you want to pay off your tuition debt in less than 20 years. So
only about 6% of people are going into family practice.
Right, but don't you think that it would make a huge difference if we invested as a nation in medical education, so that if one finishes medical school without debt, then one can go into family medicine because one loves family medicine without thinking, gee, I've got $275,000 debt to pay back. I better start doing some,
But
LASIK
seriously, Gail,
surgery.
I do think Obama has a proposal on that. I think there is a pending proposal in Congress, either in this legislation or separately or in his budget, to finance medical education.
It's not in the omnibus bill, but it was pointed out as a glaring hole in the bill.
Yeah.
So it's in an amendment.
Oh, yeah, sure. Have we got a microphone up there? Shoot.
Good morning. I have a question regarding maintaining innovation, as Dr. Sanders referred to, but also a part of the debate that I think is underappreciated. And that is, I think there's an incompatibility between the political calendar and the medical research calendar. We talk about best practices and all of that, and I had the great pleasure of graduating from the public policy school and the medical school here. But went on to training at the National Cancer Institute, where every single patient was on a research protocol. Just think how quickly we could advance, we could find out what works and what doesn't work if everybody was on a research protocol. So what is my specific question? Would you be willing to support a proposal that links coverage to participation in research protocols? That would immediately bring in the insurance industry, which is famous for denying coverage if it's on a research protocol because they say it's experimental. But it would also sort of mandate participation of the enormous Medicare population and growing Medicare population into research protocols so that we could more quickly find out what works and what doesn't work. And there's no way it's going to get into a 4-year president's terms result. Clinical trials may take decades, and I think that is underappreciated. So I'll stop with that.
Just before you answer, I want to try to translate to make sure in case some people don't fully understand the question, which I didn't either. Is he suggesting that we change insurance reimbursements so that treatment regimens which are not standard issue covered get covered because that will advance knowledge much faster in terms of what works? Is that what it was?
Yeah, I think that's a really good idea. I would probably start out with the collection of data as opposed to imposing experimental therapies on patients. One of the reasons why, I know we're both in medicine, we're colleagues, and one of the big problems is figuring out what it is that we're already doing right and why. There's so much of what we do that is sort of handed down from master to apprentice because it works without being tested. And there are many examples of things we always do because we know it to be right that would never be able to subject themselves to randomized prospective controlled trials. It would be unethical to do that, and yet we know it's right. So I think this is what I meant when I was talking about using health IT and drop-down menus in a patient care record that would be an interface between the clinical and the policy world to try to find out at each step along the way what it is that we are doing that works. And that already is a research protocol because prospective monitoring of patients, even de-identified information, involves some potential lack of privacy. But if we could do that, and as a first step to your very good suggestion, and use that to figure out what our best practices are that we're already doing, then the next step would be using that system to identify patients who might very well benefit from a drug or a treatment or radiation therapy that we don't know the effects of, and then they can have informed consent and go into those double-blind, prospective, randomized controlled trials.
I would submit that that's the only way we'll reduce costs and maintain innovation.
Yeah.
Thank you.
Very good suggestion.
Time for 2 more questions, and we got 2 people standing right here. Go ahead.
Hi, thank you. I was wondering if you could go into greater detail on what you feel the appropriate role for regulation will play in the new healthcare system, and maybe what some best practices or lessons learned from other forms of government regulation, how that might play a role in developing this one.
Well, that's a very good question. I mean, there's many layers of government regulation, so you may want to be more specific about what you're asking. County, state, federal. One of the things that I think is a good idea that I obviously do, I threw it out, was the notion of a Federal Reserve Board for healthcare. And this is a composite formulation. If we were to follow, say, the creation, the manner in which the Federal Reserve Board for Banking was created, where you would have both presidential appointees who have some expertise, who are then confirmed by the Senate, as well as locally grown and elected representatives from quadrants or regions who together would be federal experts who would help decide on an appropriate budget and appropriate things that become treatments that become reimbursable. So that's a way of regulating that's sort of extra legislative, and I would be in favor of that. It's another way of getting a handle on the cost. Thank you for your question.
Dr. Rosseau, as a physician, I agree entirely with your comments about the malpractice issue.
We call it liability because it's not
liability
really
issue.
malpractice, it's liability.
And
Sometimes it's malpractice.
and you've said why we need it. Now, could you tell me how we attain it?
How we attain
How we attain the reform when we have a system which is so embedded with lobbying for people's personal interests? How are we going to achieve that reform of the system?
Yeah, let me just address your comment. There is, medical malpractice is, operating on the wrong limb, on the wrong side of the head. Yes, that exists, and that's criminal, and every doctor I have ever known is against that and is for full punishment under the law for malpractice. And that's a very tiny part of what we're talking about, though, when we're talking about the liability issues for poor outcomes.
I once went to my dentist for a cracked tooth, and about a
Oh,
week,
well, the dentists, they all do
About-
malpractice.
about-
We're talking about doctors.
about a week later, I was still having this pain in the tooth, and after about a week, he said, it's normal, you've had some trauma, from the surgery and everything like that. And then about 2 weeks later, I was still having this pain, and I went in, and he says, dang, I did the wrong tooth. Sorry, I didn't sue him.
That it's very illustrative, though. He was honest with you. Yeah. He did do the wrong thing. It was malpractice, but you didn't sue him because he admitted it, so it was disclosure. I assumed he apologized.
He did.
And then he compensated you in that he did the right thing, and he probably didn't charge you for it.
Well, actually, he did the right tooth, and he said he wasn't charging me for the first
For the wrong one. I'm going to recommend my dentist to you.
Okay, last thing before we wrap up. How many people here would vote for Gail's confirmation as Surgeon General in a second Barack Obama term? You're good.
Thank you.